What we're going to do today is we're going to do the 15-minute presentation on patient assessment. This is David Crisp. He's been a medic for a long time, works at Cherokee Tribal EMS. My name's Clay Vinson. I work for Macon County EMS. I did my 45-minute presentation on patient assessment. Now I'm going to demonstrate how we do this as we walk in. The scenario is we get called out to a breathing treatment call, a breathing problem call. Once we arrive, the patient states that they were out working in the yard, pollen's really bad. They have asthma, but they did a nebulizer at home and feel a little better, but I'm still going to show you the assessment. So this is what we do when we come in. First thing I would do is say, hey, my name's Clay, what is your name?
I'm David.
David, what's going on today?
I had a little bit of wheezing after I was out in the yard working.
Okay, all right, do you mind if I take a pulse?
No good.
All right, what did you do after you felt yourself wheezing?
I eased back to the house and got my nebulizer, sat on the porch and took one treatment.
Okay, to make you feel any better?
Yeah, almost instantly.
Almost instantly? Okay, do you know what day it is?
It's Friday.
It's Friday. What do you know who the president is?
It's Trump.
Okay, when's your birthday?
It's March 21st of '69.
Okay, cool. All right, so what we're looking for here is, now that we have seen that he can answer my questions, that he knows where he's at, he's alert to person, place, and time. We have an alert patient. I'm still going to do an assessment. I'm going to ask him, does he have any pain anywhere? Are you hurting anywhere?
No.
No, not at all. So, and it's fully clear. You cleared yourself out. You don't feel like you need to cough or anything like that, right?
There's no struggle.
No more trouble. Okay, so what I would end up doing here is I would probably step around, ask him if I could check his lung sounds. And I would do that on the back. If he feels like he can lean forward, I'd check all 4 fields on the back, right? If I get good compliance there, everything's good, probably what I do from there is go ahead and check him on the front. I get a set of vital signs. We can skip down to a focused history. What kind of medical history do you have?
Just the asthma and psoriatic arthritis.
Psoriatic arthritis. Okay, so this is the only thing you have breathing wise is the asthma. You don't have COPD or CHF or anything like that. All right, so from there I would go ahead and check lung sounds, even maybe in the front. Get a set of vital signs, which means I would get heart rate, blood pressure. I would ask him if I could stick a finger, check CBG. I'd get an O2 sat, probably with a pulse ox, and I would check the respiratory rate. And that gets him into this. This is the alert patient. And the next thing I'll do is ask him, would you like to go to the hospital?
I don't think so today.
Okay, all right. So from there, when he says that and he can answer all of them, you say, okay, well, if that's the case, what were you doing when it started?
I was out cleaning leaves out of the flower bed around the front of the house.
Okay, so you got there and it's pollen time, it's flu time. Maybe it doesn't feel anything like it's a flu. This is basically a breathing problem. And you took care of it in about 3 minutes with a nebulized treatment. What kind of medications are you on?
I take Protonics for reflux,
Mm-hmm.
and then I take Lisinopril for blood pressure.
Okay, all right. And do you do a Duoneb or you just do albuterol?
Albuterol.
Albuterol. So there's no Duoneb there. You don't have the ibuprofen mixed with it, right?
No.
Okay, all right. So in this scenario, you want to do your sample history. When's the last time that you ate?
Breakfast about 8:30 this morning.
Okay, are you allergic to any medications?
None.
None? And he's told us the medications that he takes. What'd you have for breakfast?
Just a sausage biscuit.
Sausage biscuit. Did it cause any heartburn or anything like that?
No.
So the Protonics work pretty well?
Yep.
Okay. All right, so as we've done this, we talked about it, how long ago, we can go to the OPQRST. How long ago did it start?
It's probably been 30 minutes now.
30 minutes, okay. Did anything other than the nebulized treatment, did that help? Did anything else help? Did it help to walk around, or was it that making you struggle a little worse?
No, it was about the same till I got on the porch, and when I took the medication, then I could tell right then. It was
Okay.
helping.
All right. So if you're sitting here with this patient and things change any at all, you can give another treatment. We could do a nebulized treatment with a Duaneb if we hear some fluid in his lungs. That may help clear out a little bit. We don't want to do it if they have a patient with CHF. The COPD, it may help. But with this patient right here, basically what we would do is say, okay, if you don't want to go to the hospital, would you mind signing a refusal form for me?
I can do that. Okay,
and from there, that's basically an alert patient. Now, I'll step over into maybe someone who's not alert, someone who is who's looking at maybe a painful state, someone who can't say anything to me. One of the things I want to say, basically that patient's going to be laying down. He's not going to be sitting up. I'm not going to lay him down. I've had knee surgery. I'm not going to lay him down. So in that situation, things are a little bit different. That becomes a high priority patient, and you need to go ahead and get him to the truck. This whole entire thing should take about 60 seconds. Okay? The general impression takes about 60 seconds, and you get it. This is mostly what we deal with. That's why I wanted to do it. The next thing we'll do is we'll run through a rapid trauma assessment, and we'll talk a little bit about what goes on there. With this portion of it, we're going to do the rapid trauma assessment. I'm going to do it, and then I'm going to sit and talk about it, get him off his table, because David is not comfortable like anyone else wouldn't be. So basically what we're doing, we've gone to an MEC with a rollover. I find David not conscious. He is, and the thing to do is I'm going to say this, and it's something that is not done very well most of the time, but this patient needs to be exposed. We need to have clothes off of them. Be as discreet as you can. That's what we have sheets for. But basically, we have pulled up. Law enforcement has cleared the scene. We have our PPE on. We got everything on we're supposed to have on. And to do the rapid trauma assessment, the first thing I'm going to do is I'm going to check his head. I'm going to look at him from the top of his head down to his jaws. There's several times I've been told, hey, look, you want to wait to check the eyes until you're through with it. I like to check them because if I've got one that's dilated, one that's pinpoint, I know there's something wrong there. Anything, what we're doing is looking for life threat. We're looking for, is there gray matter coming out of the back of his head? And, you know, that gives us a scenario. So I'm going to look at him, I'm going to look at his mouth, make sure he's still got all his teeth. If he doesn't, look in the airway, don't stick your fingers in there. Do an assessment around the mandible, orbital socket, whole 9 yards. You want to look at his ear. If he's got drainage coming out of his ear, we can do the halo test, okay? This is done very quickly. The next thing we'll do is look at his neck. Does he have tracheal deviation? Does he have JVD? If he doesn't, we're moving on, you know? Most of the time, the JVD is going to be late, but we'll talk about in a minute. So the next thing I want to do is check shoulders and his chest. I'm looking for equal rise and chest fall while he's breathing. We're going to look for a flail chest. We're going to listen and see if there's air coming through, if he's passing air back and forth. If he's not, we address it right then. It could be a hemopneumo, it could be a pneumothorax or a hemopneumo, either one. We may have to do a needle decompression for that, but we're going to keep going. We're going to go down, check his ribs, check for flail segment. Check for puncture wounds. Maybe he's got a sucking chest wound that we need to cover with occlusive dressing. From there, we're going to go straight on down to the abdomen. We're going to feel for rigidity. We're going to look around the umbilicus for the colon sign. We're going to look over on his flanks to see that Gray-Turner deal, that Gray-Turner syndrome that's obviously, and something's wrong internally in the abdomen where it could be bleeding. Next thing we want to do is we want to do a pelvic exam. We're going to mash. Make sure the continuity and stability. We take the outside of our hand, check the symphysis pubis. I'm not going to do it on David. He's not going to like that, so I'm just not going to do it. We come down and check the legs. Make sure for a femur fracture. Make sure the patellas are where they're supposed to be. We're going to rub down all the way to the feet, right? Now, then we're going to get the arms, right? We're going to run down, make sure there's the decap BTLS, the things we talked about in the lecture. That is what we're looking for here. All right, if you want to scoot over. Now, in this situation, we'd have him in a neck collar, in a C collar, and we're going to roll David. I'm going to simulate it, And I would if I can't get him rolled up on this arm, I put it above his head. I'm not gonna do that to him. That's just pure and simple meaning. All right, he's on his side. We do a whole check on his back, right? On the top, when we were checking his neck a while ago, we should have done his cervical spine. Look to see if there's any step off. We're gonna all the way down, check the back of his legs, his buttocks. By the way, he is exposed now. So what I'm gonna do is I'm gonna let David get up and get out of the picture if he wants to. And so that is basically a rapid trauma segment. Let me get over here where I can talk in front of the camera. What we're looking for here is a DCAT BTLS. We're looking for life threats. When you check a head, you want to look for lacerations. You want to feel from the top of the head all the way down to the neck, right? If he's got the raccoon eyes, if he's got battle signs, that is the type thing that makes this guy a very high priority patient. Most of the time when you find them unconscious after a wreck, they are going to be high priority patients. This is something that we will work on a lot in class. If I had you in class, this is something we would take our time on and go all the way through. So while we're looking at the head, we're going to look at pupils. If they're pinpoint, what does that tell you? It tells you maybe taking an opioid, maybe we can change it. We can get him, if we give him some Narcan, that may wake him up enough to talk to us. If one's blown wide open and one's pinpoint, if it's on the patient's left side, we know we got a right side of brain problem, right? Get to the mouth, make sure the teeth are intact. He may have something lies in the back of his throat, something we can take a set of McGill forceps and take out. Don't ever put your fingers in there. So basically what I did was got him off the table because it's exceptionally uncomfortable. But you check the cervical spine for step off, okay? I have a younger brother who is quadriplegic because he broke his neck. This is something that we're gonna do and make sure we get a C-collar on him. Make sure we can see that. Make sure you check that. If you feel a step off, it'll be a deformity in the cervical spine and all the way down the spine, as a matter of fact. But it'll be a step off and you'll feel a deformity in there. That means that neck is compromised. In that situation, you're probably looking at going to a trauma center that has neurology, a neurologist there that can do. My brother's stayed 39 days at Shepherd Spinal Center. If we can airlift people to that, if we think that's what needs to happen, we can do that. Most of the time they do that from a hospital, but after they've had x-rays, but it's something that we have as an option. From there we go to the neck. The JVD, the tracheal deviation, many times comes from instant trauma, that there's been horrible neck trauma, or it's late in that they may have a pulmonary problem, something that's going on in their lungs, which is more apt to be what you're going to see. Something that's happened there, and it's causing a tug one way or another on the trachea. That there's been trauma inside with the pulmonary inside the pulmonary cycle. Or the tracheal deviation is somebody that's really straining the JVD is somebody that's really having a hard time, and those things will pop out. One of the things that we are looking for with the top of the shoulders, the clavicle is the most broken bone in anybody's body. That's the one that's broken the most. So we do want to put our hands on that and make sure the continuity's there with the clavicle. And then we come on down. Look at the sternum. The sternum hides the heart, so we got to make sure it's all intact. And like I said, with a flailed chest, we're going to put a dressing over it, something with a little bit of pressure, and try to keep that stabilized. Where you listen to lung sounds, one of the things we want to do is make sure there's lung sounds, good air passing to and from, all the way to the bottom of the lung. If there's not, we need to address that right then. As part of the airway breathing circulation deal. The airway, make sure we got a good patent airway. If it's not, don't be afraid to dart the chest between the second and third rib on top of the third one, okay? Make sure you don't go to the bottom of it because we know we have nerves and arteries underneath each one of the ribs. From there, we go on to the admin. This is where a lot of times we know the admin can hold a lot of blood, okay? So if we got trauma there and you're going on MOI and a wreck, which is a mechanism of injury, a lot of times this is what you'll see is you'll find that abdomen is rigid, or you may find a pulsating mass where the aortic it's split down in the abdomen, and not a whole lot you can do for that patient except hurry. One of the things that I have seen many times is, we rush through this and we don't catch what's going on. The torso is where you want to concentrate. If you've got a broken leg, don't let that distract you. Even if you've got a compound fracture on an extremity, most of the time people don't die from those. What they die from is something that happens in the vital organs. So we need to make sure to do a great assessment with that, and that's where this is going to excel, is the rapid trauma. You got to be quick. You do a rapid trauma assessment and find out what's going on. If they do have a broken clavicle and they're alert enough to tell you that, hey, look, it feels like my shoulder, I've hurt my shoulder, we can, after we've done the complete assessment to front and back, then we can put them in a sling and swath and hold them still. But it's only after that. So if we find that we have dislocated kneecaps, broken femur, with a broken femur, after you've done the whole thing, looked on the back and looked at their back and checked all the way down for the spinal step off, and the decap BTLS even on the back, then we can splint that femur. We can use a traction splint and get it there. We've all got them on our ambulances. So the best way to do that is, it's an organized chaos. You get it done, you note what's wrong, and then when you get them in the truck, you can fix most of the things that's going on, the things that you can fix. I hope this has been informative. I hope this is something that we can use maybe a little later on. I love teaching this stuff, and I appreciate your time.